to introduce the members of this committee. We have present today a Vice Chair, Representative Leila Staffler, Representative Donald Manglonia, and Representative Sheila Babalta. Representative BJ Attel is off island on personal leave, and he is excused for today. Staffing the committee is our Legislative Assistant, Ms. Claire Sablon, and our new House Counsel, welcome, Mr. Brendan Lade. And with that, we have a quorum. May I have a motion, please, to adopt the agenda?
Motion to adopt.
Motion has been made and seconded. All in favor of adopting our agenda for today, please say aye.
Aye.
All opposed, say nay. Thank you. Motion carries. Please turn off all cell phones in the chamber. Thank you. Moving along to our next item of business is the adoption of meeting minutes. Colleagues, you all have a copy of the meeting minutes provided for February 12th, February 26th, April 30th, and then our medical referral public hearings on Rhoda, Tinian, and Saipan on May 6th, May 10th, May 21st, and May 26th, as well as our last meeting on June 10th, 2021. At this time, may I have a motion to adopt the meeting minutes, or are there any proposed amendments or?
May I?
Yes.
I'd like to motion to have any technical grammar errors and things to be corrected in the minutes prior to, or just to be corrected in the minutes.
Okay.
So moved.
So this is a motion to adopt the meeting minutes
To correct any technical.
and correct technical
yes,
corrections.
Yes, that is what my motion is.
Okay. Thank you. So clarified. And the motion has been made and seconded. And that motion, just to be clear, is to adopt the meeting minutes that appear in today's agenda to make any technical corrections before filing with the clerk. And we will take care of that. Okay. Any discussion? All in favor of adopting today's meeting minutes, please say aye. All opposed, say nay. Motion carries. Next in our order of business is public comments. And we'd like to ask that those who are providing oral testimony today limit their comments to 3 minutes. If you need additional time, we may grant that up to 5 minutes. And we will also be accepting longer written testimonies. And you can submit your written testimonies to our Sergeant at Arms. Wave your hands. Thank you, Sergeant. Okay, the floor is now open. The Sergeant at Arms will escort you. If we could ask our speakers to come into the gallery or come into the chambers, please, and have a seat in the center. Good morning and welcome. Who would like to start first? Okay, Ms. Salas, if you could please speak into the microphone when you offer your testimony and also state your full name and position for the record.
Good morning, everyone. My name is Frances Torres Salas. I'm the Director of the Office of Personnel Management. Thank you, Representative, and this body for allowing me to make comment on House Bill 22-53. Dear Representative Sablon and committee members, thank you for the opportunity again to provide these comments on House Bill 22-53, which states to further enable recruitment, retention, and appropriate classification and compensation, Medicaid personnel, and for other purposes. It is unfortunate that OPM was not afforded the opportunity to comment on Public Law 21-28 during its initial stage of promulgation. Perhaps if we had, we wouldn't be in this current predicament. But nonetheless, OPM is ready to provide clarification and guidance on the matter. OPM immediately started a dialogue with the state Medicaid office after learning about Public Law 2128 and the need to convert the office staff to civil service status. The classification and compensation section of OPM took the lead on the conversion process and worked closely with the management of the state Medicaid office. The classification and compensation section provided proposed minimum qualification requirements for positions currently within the Medicaid office that were similar in nature to positions already established in the Master Class Index. Position descriptions and scope of work for those positions that needed to be established were prepared and forwarded to the Civil Service Commission for review and approval. This whole process required a desk audit, and that is what was done. With any desk audit, salary compensation and scope of work is evaluated and conclude with an upgraded position description and possibly a salary adjustment. In the case of the Medicaid office, several positions required a modification to salary. House Bill 22-53, subsection 20211, proposes to implement two distinct employment statuses, either to be civil service or to be an accepted service contract employee. It is my opinion that this is not acceptable. Public Law 2128 clearly states that all employees of the state Medicaid office shall be converted to the Civil Service Act. The following sentence should be struck out from House Bill 22-53. MES employees may elect to convert to civil service when a classification and a compensation study is completed by the Office of Personnel Management and approved or modified by the Medicaid director. Employees should not be given a choice just because they're not satisfied with the proposed salary. Employees should qualify for positions and be paid appropriately as civil service employees. There are provisions in place that cover contractual employees. First, the position must be designated hard to fill and special and unique. In this case, MES could possibly be considered both hard to fill and special and unique. Also, the employee must possess credentials, specialized training, and certification or a specialized degree to qualify as an accepted service contract employee in agencies that fall under the civil service. Public Law 21-09 provides a cap of $65,175 for these contractual employees. On the other hand, if the position is to be established and become part of the Master Class Index of classified positions, then the position would be announced to get a pool of qualified individuals. Civil service positions must be open for individuals to compete. It is very evident after the audit review that the state Medicaid office is trying to accommodate certain individuals who want the higher contractual salary, even though they don't meet the minimum accepted service qualification requirements. House Bill 22-53 also proposes for OPM to conduct a compensation comparison with the Commonwealth Healthcare Corporation. This would be counterproductive. CHCC personnel are primarily in a contractual status, and as far as compensation, the central government cannot compete with salaries of CHC employees. The salaries there are much higher. Additionally, the text of the House bill in Section 4, reenactment of 1 CMC subsection 20211, states that when a classification and compensation study is completed by the Office of Personnel Management and approved or modified by the Medicaid director, this statement ignores the fact that class specifications and compensation standards are subject to the final approval of the Civil Service Commission, not the agency director. Or even greater concern is the question of whether this House bill, in its efforts to establish and manipulate the both civil service and accepted service qualifications and compensation, is in violation of the Civil Service Commission's constitutional authority to establish and administer personnel policies for the Commonwealth government, which includes position qualifications, and compensation. So overall, after presenting all of this, I'm not in support of this House bill. But hopefully we can come to a solution. Thank you.
Thank you, Director. And just to be clear, your comments are pertaining to the substitute legislation that we sent you.
Yes.
Yes. Okay. Thank you. Are there any questions at this time for Director Salas? Thank you. Administrator Sablan, are you ready to proceed? Thank you. Sorry, Ms. Sablan, I think we need to fix your mic.
Yeah, yesterday it wasn't working. During
Good morning, Chair Sablon, Vice Chair Staffler, and members of the Health and Welfare Committee. My name is Helen Sablon, Director of the Commonwealth Medicaid Agency. Thank you for the opportunity to be here to provide any support, to provide my support and comments on House Bill 22-53. The Commonwealth Medicaid Agency strongly supports and is in dire need for the passage of House Bill 22-53 in order to hire the Medicaid enterprise system and compliance personnel as required to meet the federal mandates and implement CNMI Public Law 21-28 that recognizes the need for MES and compliance programs and illustrates the policy level involvement and oversight to ensure that the CNMI will make reasonable and appropriate progress to improve the current eligibility and enrollment and to implement a Medicaid management information system, claims processing with full capabilities to submit data to the transformed Medicaid statistical information. On October 1, 2020, the CMA received its approval letter from CMS to support the positions needed for the MES and compliance program. However, today, the CMA has only one personnel supporting these efforts of the program and project activities. The CMA has already lost 10 months in time in hiring the personnel needed to move forward with the project activities on improving the accuracy and efficiency of claims processing, use of data for program integrity, and ability to submit to the TMCs. On August 17, 2021, the CMA received the approval letter to continue its support to fund the program and project activities for fiscal year 2022, to initiate the collection, the claims data file electronically in a secure data enclave, and to conduct data management and initiate the data analysis to assess the comparative cost of care, quality of care, gaps in services, and other purposes. These activities demonstrate the CMA's commitment to effectively administer the Medicaid program, even with the limited resources and the major challenges the CMA confronts on a daily basis to improve the care of our U.S. citizen members. Once again, the CMA strongly supports this HB 22-53. Thank you, members, for your support in addressing the Medicaid program challenges. Should there be further questions, please do not hesitate in letting us know. Thank you.
Thank you very much, Director Sablan. And if you could both provide your written copies, if you haven't already, thank you. Members, do you have any questions for Ms. Sablan? I have just one question. If you would be willing to just briefly address the concerns that have been raised by our OPM director with respect to I guess, and to clarify, your comments and support are related to the substitute bill that our vice chair will be formally introducing today, right?
Yes.
Thank you. Are you able to address at this time the concerns that the OPM director has raised about those provisions?
Yes, so if we can't, do the price studying, because it's really, I mean, we're the same with CHCC, handling the healthcare services for our people. And it's really hard to get people or qualified people on board to, for these positions for this project. And this is as a result of the Consolidated Appropriations Act, which was approved by the U.S. Congress. This is mandated that we should get these people on board so that we can move on with this project. But in the meantime, if we can just hire these people under the accepted services contract, and then we can eventually, if they can establish the positions in the classification index under the civil service, then we can, you know, convert them.
hmm And it is still the position of the Medicaid agency that all of the staff should eventually transition over to the civil service system.
Yes.
Okay. Thank you. And just a real quick question for Director Salas. You said that it would be, or it sounded like you didn't think it would be possible to do this repricing study and to make the salaries that are offered in the Medicaid agency competitive with CHCC, and that the central government can't compete in the civil service system with the salaries established by CHCC. Could you just clarify that part, please?
Okay, so from my understanding and from what we have learned, CHC offers their employees much, much higher salary compensation compared to the central government. With the central government, we have laws in place that cap contractual employees at a certain amount, which is at 65,175. I believe the state Medicaid office for these specific MES positions are requesting for salaries beyond that. So again, we need to work within our limits.
But there are also
Um,
exceptions in the law to that salary
Yes.
cap for critical personnel that are essential for
Yes.
compliance
So-
with federal grants.
Correct.
Right?
So
In which
perhaps-
case,
Yes,
Yeah.
so perhaps we can amend that particular law to include those positions.
okay. But
You
these
know,
are
because right now it's for doctors, engineers, architects, people with specialized skills.
but also people who are critical for compliance. That was just amended. And Council, you're nodding. Do you have that in front of you?
I'm looking at
Yeah.
2021,
Yeah.
which includes the,
Sorry, could you use your mic, please?
I'm sorry, I'm looking at Public Law 21.
Push the
You
button
need to push the button.
down below. There.
Sorry
Yeah.
about that.
There you go. He's
I'm-
brand new. So thank you. Go ahead.
I'm just looking at Public Law 21-9, which provides for the exemption from the salary cap for medical professionals and various other critical personnel, and also has language about personnel needed to meet federally funded grant objectives.
Okay. And so you're saying, Director Salas, that the Medicaid staff could fall under that?
Yes, absolutely.
Okay.
And anything I believe beyond the salary cap mentioned, they must write to the House or the legislature to inform them of the over the salary cap.
They being, in this
believe-
case, the Medicaid director?
Yes.
Okay.
Okay.
Right.
Yeah.
Okay.
Again, my thought is, I don't think we should give them a choice. It's either you there's law that says you are converted to civil service.
Mhm.
You know, so I mean,
Right, but this legislation proposes to amend that law.
yes, absolutely.
And so, and then one final clarifying question. You suggested that what's being proposed in this substitute bill may violate the constitutional authority of the Civil Service Commission.
Yes.
Do you have a legal opinion from the Civil Service Commission's counsel, or from the Attorney General, for that matter, that would address
We
that?
could obtain one, but
Okay.
yeah, they are the governing body when it comes to such.
Okay.
So
Perhaps we could
We
take
could-
that up with you after.
Yes,
the session.
absolutely.
Okay. All right. Thank you both. Are there any further comments before we excuse you and receive other testimonies? Yes.
Thank you.
Representative Abata.
Thank you, Chair. I just have two questions, just clarifying questions for OPM Director Salas. In your statement, you did mention that the proposed minimum qualifications requirements for positions that are similar in nature were used to establish the position description and scope of work and salary. What were those positions that are similar in
Most
nature?
of them were for the current staff, eligibility workers, eligibility claims examiners, the current staff. So when we converted them, we had to find appropriate titles and salaries that would match exactly what they were basically performing as far as their duties and responsibilities.
Right, but you compared them to existing roles and positions in our government,
Yes,
right?
in
What
our
were
master
those existing roles that you compared it to
Claim-
come up with the salary?
yes, the claims examiner positions,
And that's with the
eligibility.
Medicaid office?
Yeah.
Oh, existing roles with the Medicaid
Existing,
office. So
yes.
there are employees under the Medicaid office that are civil service employees.
They are all
They
now.
are now,
Yeah.
yeah.
So clarified.
Before they were accepted services.
Got it. Okay.
And now with the Public Law 21-28, they have
They
to
were
be
converted.
converted to civil service.
And you did mention, Director Salas, that it was forwarded to the Civil Service Commission for review and approval. Is there a status update on that?
It's done. We're all done.
Okay, okay.
We're done with the conversion. It's just that a few positions, people who were in a particular position were not satisfied, were not happy,
Mm,
or did not want to be converted
mm.
because of the salary, distinction. So, I mean, therefore, then their contract should end, and and also I just want to comment that
Okay.
something that the Medicaid office director mentioned was that I believe we should open these positions of these MES positions and have them announced and get a bigger pool of applicants. Because maybe there are people out there that actually have the credentials. We don't know because we haven't announced them yet.
Okay,
Okay, thank
so
you.
clarified. Thank you, Chairwoman.
Thank you, Representative Abata. And thank you both for your testimonies today. We will be introducing formally the substitute bill and adopting it as a replacement bill for the original House Bill 2253. But we will likely entertain additional amendments, and we will consult with both of you. Thank you.
Thank you.
And at this time, the floor is open for other public comments on any item on this agenda. Good morning, welcome, and if you could please state your names and the agencies you're representing, and if you have written testimony, please provide that to the Sergeant at Arms. And you may proceed. Who's going first?
Good morning.
Good morning.
Good morning, Chair, Vice Chair Staffler. My name is Monica Chrysostomo, and I'm with CHCC. Thank you for the opportunity to provide testimony regarding House Bill 22-68 to establish a prescription drug monitoring program system in the Commonwealth of the Northern Mariana Islands. Again, my name is Monica Chrysostomo. I'm the acting manager and PDMP coordinator for the Overdose Data to Action program under the Commonwealth Healthcare Corporation. My testimony today will focus on the creation and operation of the CNMI CHCC prescription drug monitoring program system as a patient safety tool. The OD2A program was born in 2019 out of a 4-year cooperative agreement between the Center for Disease Control and Prevention and the Commonwealth Healthcare Corporation, focusing on complex and changing nature of drug overdose epidemic and highlighting the need for an integrative and extensive public health approach. OD2A aims to prevent opioid-related harm and overdose by incorporating prescription drug monitoring program data to identify and monitor emerging drug trends and direct prevention activities, increase public awareness about the risk of prescription and illicit opioids and other controlled substances, and 3, coordinate with public health and safety and community-based partners to rapidly identify overdose threats, reverse overdoses, and link people to effective addiction treatment services. I've been involved with the CNMI CHCC PDMP since its implementation stage. Its launch last January 31st, 2021 into the present. It's the first of its kind here in the CNMI, but the last nationally for a U.S. jurisdiction to implement. In its simplest form, the CNMI CHCC PDMP is an electronic web-based database system that tracks all dispensed medication data on opioids and other prescription medications from all pharmacies in the CNMI. The PDMP is a tool to help promote safe prescribing and dispensing of opioids and other controlled substances prescription drugs. It is widely used across U.S. states and territories for combating the opioid epidemic by helping to prevent prescription drug misuse, abuse, diversion, addiction, and overdose. Authorized users include dispensers or pharmacists and prescribers such as physicians, physician assistants, nurse practitioners, nurse midwives, dentists, and optometrists with prescriptive authority in the CNMI. Authorized users are able to register for access to the PDMP system by validating their information using a two-step process. First, authorized user information is submitted to the OD2A program by the hospital or the clinics or pharmacies. The information is then preloaded into the system database. Once this process is completed, authorized users are invited to register by going to the PDMP website at pdmp.chcc.gov.mp and completing their registration using the Sign Up button. Registration information is then validated against the system database and access will be granted when the information is authenticated. The system is designed to be used as a tool that allows authorized users to query a patient's prescription history to inform their prescribing decisions. CNMI pharmacies submit dispensed medication data on a volunteer basis by the close of the next business day following dispensation. The system accepts information using the American Society for Automation in Pharmacy Standard version 4.2a. Dispensed prescription information such as patient, prescriber, pharmacy, and drug information are captured. Authorized users are able to view what patients have picked up from any of the CNMI pharmacies by querying a patient using first name, last name, date of birth, and phone number for better patient matching. The information is displayed in a patient report using a grid and a graph view. Both display the same information such as patient information, overdose risk score, daily morphine milligram equivalent levels, and dispensed prescription history. The system also displays dispensed prescription history by drug class that can easily identify overlapping prescriptions over time. Authorized users can use this information to prescribe safe and effective treatments by avoiding dangerous drug interactions and combinations of such as co-prescriptions of an opioid, a benzodiazepine, or a muscle relaxant to further reduce opioid-related harm, abuse, and overdose. The grid view, which lists out dispensed prescription history, allows authorized users to facilitate better coordination of care to patients seeing multiple providers by identifying individuals who may be dependent or developing addiction to monitored substances to provide intervention as well as referral to additional behavioral health treatments. CHCC also aims to broaden the scope of the PDMP system with a more comprehensive approach to monitor all controlled and non-controlled substances dispensed in the CNMI, using the PDMP data collection and analysis to meet its mission to ensure accountability and adherence to prescribing practices that affect overall health and welfare of the CNMI population, especially for conditions and diseases related to cancer, diabetes, cardio and cerebrovascular diseases, and renal disease. The PDMP will enable CHCC to monitor the care and treatment of patient medications, provide information to improve the health and safety of our patients, and help prevent the misuse of prescribed, controlled, and non-controlled substances. Thank you again, Chair Sablon, Vice Chair Saffler, and honorable members of this committee for the opportunity to share this information with you about the CNMI CHCC PDMP system and its role in addressing the CNMI's prevention efforts to stay ahead of the opioid crisis impacting many of our fellow American state and territories. The CNMI CHCC PDMP system would not have been possible without the involvement of the CDC through its cooperative agreement awarded to CHCC to proactively combat and prevent opioid-involved abuse, addiction, and overdose. Thank you.
Thank you very much, Ms. Chrysostomo. Ma'am, would you like to proceed? Thank you.
Good morning, Chair Sablan, Vice Chair Staff. Oh, this is not working. Yes.
Thank you.
Good morning, Chair Sablan. Can you hear me better now? Let it go? Okay. Good morning, Chair Sablan, Vice Chair Staffler, members of the committee, legal counsel, and staff. My name is Eleanor Cabrera. Please excuse my voice. Like many people are across the CNMI, I'm getting over a cold. I'm Eleanor Cabrera. I'm the exiting manager for the Overdose Data to Action Program and the PDMP administrator for CHCC. In January 2020, I was brought in and tasked to develop a team to honor the cooperative agreement between the CHCC and the CDC to initiate two components of the agreement, which was the surveillance aspect of it. Prior to that, there was no surveillance activity across CHCC or the CNMI to track and monitor opioid dispensation, opioid misuse, dependence, addiction, or overdose that would be detected in encounters throughout the CHCC, as well as develop the prescription drug monitoring program system. Monica Chrysostomo had joined me shortly thereafter, and the rest of the team also present today. I will not duplicate what Monica has been able to very clearly testify on what has transpired since January 2020. But really to be able to also make myself available to answer any questions the committee may have at this juncture. But also to say that the PDMP was authorized by the CHCC and given full authority by Public Law 16-51 to provide the people of the CNMI quality health care and to expand the level of medical and other public healthcare services available. And the PDMP is a prime example of that expansion of services made available for our people. The PDMP has enabled the CHCC to monitor the care and treatment of patient medications, provide information to improve health and safety of our patients, and to reduce the misuse of prescribed controlled and non-controlled substances, and help prevent substance use disorders and overdose deaths in the CNMI. And the PDMP system allows us to be able to carry out really all forms and levels of prevention, primary prevention, secondary prevention, and tertiary prevention efforts to stay ahead of what is experienced nationally across U.S. states and territories with respect to the opioid epidemic. And through our surveillance numbers, it's very clear that we have prescription opioid misuse, abuse, and addiction here in the CNMI. And in 2020, there are encounters of opioid-involved overdose, non-fatal, non-accidental overdose. This is very clear data. This is the information that is leading us to inform our prevention activities, and the PDMP system stands as a significant tool to safeguard patients in the Commonwealth. Thank you.
Thank you, Ms. Cabrera. Members, do you have any questions for either Ms. Chrysostomo or Ms. Cabrera? Vice Chair Staffler.
If you would please repeat the data that you mentioned at the end. I didn't hear it clearly. And
I'm sorry.
that's okay.
Okay.
I love data, so I'm very
Okay.
curious about what you were saying as far
Yes.
as what evidence we have.
Okay. For the OD2A program with respect to our surveillance activities in 2020, and this was also shared, thank you for the opportunity a few months ago with the informational session. The 2020 counts, we had 22 encounters when looking and analyzing all emergency room visits, 22 encounters of opioid involved misuse confirmed and suspected. We had 20 overdose cases involving other substances. For 2021 to date, through quarters 1 and 2, through our epidemiology weekly surveillance reports, we have a combined number of 30 now cases of opioid involved misuse. And we have, I believe, over 15, I believe, of the overdose cases of other substances. So while we are also tasked to have been detecting any cases involved with opioids, we are also a program that's very much concerned about other substances. So we have been tracking overdoses of other substances. The OD2A program with Monica Kusasamo at the helm will be looking at also stimulant misuse, both prescription and illicit, which CDC has afforded the opportunity to be able to expand. And of course, all of these medications are able to be provided through the features of the PDMP system too.
Thank you for the clarification and just adding on to the bigger picture of what our community is going through. I appreciate it.
You're welcome.
I have a question. Maybe either or both of you could address it. Could you address what the policy rationale is for collecting also data related to non-controlled substances? So it is our understanding, based on other comments that we've received, that almost all states only require the collection of controlled substance data. So what is the rationale for requiring all prescription data, both controlled and uncontrolled, non-controlled?
Yes. So the vast majority of jurisdictions do only track the controlled substances. It's important to understand too the background. A lot of the states had developed these systems decades ago, and so there are jurisdictions that are moving towards consideration of including other non-controlled substances. So that is definitely in consideration of future attempts to revise legislation to accommodate for that, as is the state of Nebraska had done. And the rationale is the same. First of all, there are non-controlled substances that do have dependence and abuse potential that may not necessarily be included in the classifications under DEA regulations. And then also the CHCC, in an effort to carry out its mission of accountability to our people through our prescribing practices, is also able to use the same information and the same data from the PDMP system to see if we are also prescribing for the diseases that are really plaguing the Commonwealth, as Monica mentioned, from renal disease, cancer, cardiovascular or cerebral vascular disease, etc. So the premise is the same in wanting to be able to see if physicians have the information, prescribers and dispensers have information available to account for whether or not a patient's care needs to be modified or taken in the direction of prescribing practices that are more aligned with scientific guidelines, CDC guidelines of how best to address those other diseases.
Okay, thank you for addressing that part. I guess my next question would be, like, what practically speaking are the consequences if providers refuse to register? I understand it's voluntary now, and from your last information session, it sounded like most providers and dispensers have registered, but what is the consequence if they don't?
So yes, it is true. So CHCC, through the support of the OD2A program, had actually developed and adopted policy requiring all of its prescribers and dispensers to register and query the system, especially when prescribing for the treatment of pain or for the treatment of opioid use disorder or other substance use disorders. And so the CHCC, of course, is not able to, expect that the private providers would adhere to those mandates, but for our own providers. So yes, it is on a volunteer basis. Currently, we have about 88% of all CNMI prescribers and dispensers registered for the system, a total of, I believe, a little over 130, which is 124 of the prescribers and dispensers plus 22 of their delegates. For CHCC, our numbers are at 97% of what currently prescribed. And those numbers go up and down because we do have a lot of temporary or locum physicians coming in and out. And there's a period of about a week where they would be required or people exiting. So those numbers fluctuate. And so there isn't currently any consequence. The consequence is within CHC currently because that is policy. And so they would have to be addressed administratively and with our own clinical and administrative leaderships. But there is no consequence per se. But the overall consequence is the inability to access comprehensive medication data to appropriately and safely prescribe for their patients, whatever their reason for the visit.
And thank you. And so this legislation that you are here to support, House Bill 2268, would make registration mandatory and
Correct.
reporting, and then would provide for penalties
Yes,
for failure to report.
correct.
Okay. Thank you. Any other questions before? Thank you, Rep. Donald Maglonia, and then we'll move to Rep. Sheila.
Thank you, Chair, and good morning, and thank you for coming in. The question that I have pertains to the administration of the program. So I understand your grant is 4 years, and so I guess I wanted to find out first what the yearly cost is to manage this program.
You wanna pronounce it?
Currently, our grant through CDC funds about $765 per year.
I'm sorry,
Thousand?
could you
For
repeat that?
765,000 every year.
And so once this grant expires, that would be the cost to CHCC?
I'd like to offer clarification for that. That is the total grant award for both the surveillance and the prevention activities. So the first year of the award was actually $1,015,000 because that was to be able to support CHCC's ability to purchase about $350,000 worth of a storage areas network access equipment and data storage capacity to support data coming in from the PDMP system. And but that is not going to be a cost that reoccurs every year. Really, you're looking for the PDMP program alone, you're looking at about 3 staff and a contractual work with the current PDMP vendor that has allowed us to establish the system. And so you're really looking at about half the amount.
Half of the
765, correct. Yes.
And that's per year on average?
Yes.
And then those that are registered, those that will be required to register into the program, would they have to pay like some kind of a subscription fee or?
No, currently there is no cost to the prescribers or dispensers registered at this time. And that's part of the cooperative agreement with CDC to be able to increase the amount of registrants and to allow for easy access and use. And so it was in the agreement not to have a financial inhibitor.
All right, thank you, Chair.
Thank you, Representative Maglonia. Representative Babata.
Thank you, Chair. And thank you, Ms. Crisostomo and Ms. Cabrera for being here. Well, my question is in regards to the language related to the penalties in place. I was just wondering if you had any feedback for the committee on the amount per violation.
No,
So-
I'm not aware of any feedback on the amount.
Okay. Well, there are different sections for a dispenser who knowingly fails to submit prescription monitoring, a dispenser who knowingly fails to correct or amend prescription monitoring, and a prescriber who knowingly fails to query But the penalties that are in place have a max of $250. So it would be levied by the professional licensing or regulatory board, but no more than $250 per violation. So I was just wondering if your team had any feedback on that amount,
No, and the team was not involved in
crafting this
crafting
legislation.
this section
Okay.
of it.
I think that's something that I'd like for your team to consider, maybe by our next committee meeting, only because, well, in my opinion, that's minimal. And then to also place a cap on the
Mhm.
amount per violation
Correct.
may not be effective if we don't talk about that.
I do see that the fines do increase as the gravity of the conditions of any violations do increase as well. And we can provide the information to CHCC leadership. The OD2A program personnel is 100% funded by this federal grant, and we are unable to be actively involved in the intricacies of that particular part of the legislation, but we can certainly inform leadership of your questions or statements about that.
Okay. And then, just my final question is in regards to the data collected on the type of drugs that are being dispensed.
Mhm.
And I am not familiar with the process or the structure of it, but will this drug monitoring program also be able to inform leaders in the CNMI of the type of drugs that are being imported? And I'm just thinking, like, to better protect our community, what drugs should we just be aware of, right? Like, if we take a step back and see all the drugs that are being imported, what are being used, what's not being used, what can we do without, and what we should not consider at this time.
Understood. And there's certainly a concern for drugs, what type of drugs are being imported. And of course, in terms of illegal channels, and the program is very much involved in working with those entities that are in charge of ensuring to protect our borders, especially when it comes to counterfeit medications and the trends that have been going across nationally for counterfeit opioids or folks thinking that they're consuming either cancer or other type of medications, but unfortunately may be laced with opioids such as fentanyl, which has very fatal consequences with minimal consumption. So I understand the concerns that you're bringing up with that. The system, however, only tracks dispensed medication that was prescribed by a prescriber with a provider with prescription authority in the CNMI, and of course, but dispensed by
Okay.
CNMI pharmacies.
So clarified. Thank you. Thanks, Chairwoman.
Thank you, Representative Abata. And so I can further understand this, what about like mail order prescription drugs? Would the system capture those if they were prescribed by an on-island registered provider?
No, the only information is submitted unless they go through the pharmacies.
Mm-hmm.
So
Okay.
the data is obtained through the pharmacies
Okay.
only.
Thank you. Okay. Are there any further questions for our witnesses today? Thank you, Ms. Crisostomo. Thank you, Ms. Cabrera. Wish you well in your next endeavor.
Thank you.
And thank you both for providing
Yeah.
this information today.
Thank you very much, committee. Thank you for the opportunity.
The floor is now open for others who wish to submit public comments.
Hi, good morning. Hello. Okay.
Good morning.
Hi, morning. Chair, Vice Chair, and committee members, thank you for allowing me to come and speak. So I wanted to comment on 2268.
Sorry, would you please just for the
Sorry.
record state your full name and the organization you're representing?
Yes, my name is Dr. Joshua Wise. I'm a pharmacist and general manager for PHI Pharmacy. So I am a dispenser for prescription medication. I'm also one of the people recently mentioned that submits the data. I just wanted to give a little background from my perspective regarding PDMP. So PHI has been doing essentially a manual version of a PDMP since around 2016. One of my pharmacists had decided one day she thought she would just call and check every time we filled a narcotic prescription, that she would call and check the other pharmacies. At the time there was only Brabu. So we would call Brabu and say, hey, has this patient picked up any narcotics in the last like few months? And we're sort of manually checking that. She was just doing that for her patients, and within the first month she found 5 patients that were getting narcotic medications from both pharmacies and different doctors. Once she brought that to my attention, we decided to make that sort of our policy, that every time we filled a narcotic or controlled substance, that we would call and do those checks. We didn't realize that there were that many people, double dipping into the system. And also most of those, are Medicaid prescriptions. So Medicaid is actually paying twice for those, which is a separate issue. But so we've tried getting a PDMP established here. We've used them back in Hawaii, where I'm from, and they're great tools to have from our end. And in Hawaii, you are required to use them. So at a certain point, it became sort of a nuisance to the other pharmacies that we're calling. It seemed like we're calling every 20 minutes. Hey, have you filled for this patient? And thankfully, since the establishment of this program, we don't have to call anymore. We can just query the system, check on the patient, and that's a lot less phone calls for both of us. But in addition to being able to monitor the narcotic and controlled substances, having I would say initially I wasn't in strong support of having all uh, uh, prescriptions submitted, but since we've been using the system now, it has been helpful in many situations where, say, an insurance will reject a claim because it'll say there's a duplicate therapy, and we're looking in our system and we don't see any duplicate therapies. We can query the system and say, oh, the patient just got the same thing at another pharmacy, or something that's a different medication but in the same class that essentially does the same thing. One example is a patient who is getting glimepiride from outpatient pharmacy and they're prescribed glyburide at our pharmacy. The patient will see different drugs and think they might be for different things, or I'm going to take both. Taking both of those medications might cause hypoglycemia and land them in the ER. So having access to something like that, and for us to being able to tell them, hey, you got this medication from this other pharmacy, don't take that anymore, you're going to take this one now, has led to safer outcomes for patients. So I do support that. I've also talked to providers about making that even a gold standard, because we've had so many providers who will check a patient's labs and see that, okay, my patient's sugars are too high, or their cholesterol is too high. And so they call the pharmacy and they're increasing their doses. And, little do they know, we're seeing in our system, well, this patient hasn't gotten their medicine in like 6 months for that condition. They don't realize that because patients don't really want to tell their doctors, oh, I'm not taking that medicine. They just say, are you taking all your medicine? Oh, yeah, I'm taking it. And so the doctors assume they're taking it, start increasing their doses, and that again can lead to worse outcomes. But I've talked to some providers and told them this can be a gold standard, that when you see your patients, you pull up their PDMP, pull up all drugs, you can actually see how compliant your patients are. and say, hey, how come you're not taking this medication? Are there any side effects going on that we need to know about? And they can ask those questions and provide better care and say, hey, okay, if you're having a side effect on this, maybe we can change the dose, or we can switch you to this other medication. So it does lead to better outcomes if it's used properly. That's essentially my take on it as a provider, and I'm welcome to any questions you guys may have.
Thank you so much, Dr. Wise, for providing that perspective. It's really helpful to hear how this actually works from the perspective of providers. And at this time, colleagues, are there any questions for Dr. Wise? Vice Chair Staffler.
It's not really a question, but it's a comment. We've talked about these kinds of things before, and I think it's pretty cool to see it in action like this. So I really am grateful that you came to share that perspective, because we've talked about that thing before. So thank you.
Yes, thank you.
Thank you, Vice Chair. Any other questions or comments? Thank you so much, Dr. Wise. And if you have any written testimony you'd like to submit, we will continue to accept written comments after
Thank
today.
you. Thank you,
Thank you.
committee.
Have a good day. Any other comments, public comments? The floor is now open.
Good morning,
Good morning.
Chair, Vice Chair, honorable members. My name is Vivian Sablan, Administrator for the Division of Youth Services under DCCA. Along with me is Mr.
Julian Camacho, Supervisor for Child Protective Services.
Good
So
morning. Welcome.
we're here in support of the foster care sponsorship bill, House Bill 22-15. We've been providing a letter of support, written support. But this morning we're just gonna give you guys a brief background. So when children are removed from home, they are usually placed temporarily at our DYS emergency shelter. However, if it is determined that it is the best interest of the child and that longer placement is needed, that's when the program seeks out for foster care placement. As of today, we have a total of 34 clients placed, I believe in 9 different households. We used to average 10 to 15 per year. In FY 2019, we were able to receive 90,000 from our local appropriation. However, in 2020, that was removed. And I think that's what kind of sparked the initiation of this discussion. So with that, we used to give $250 of stipend per child per month, just to kind of assist with the living cost. 250 is really nothing. So we actually got our granted to approve our stipend of $400 per child per month back in 2015. Today, that's still not enough. So we are kind of working to also increase that. But with the number of clients that we have at 34 today, that'll cost DYS about 163,000. And that's just as of today. So if we were to bring in more foster care clients between now and or next year, because we go by the fiscal year, it'll eventually cost us more. But we can look at it as an average. Because we lost that 90,000, we went out and tried our best to venture into other opportunities. So we were lucky enough to receive additional funding from CJPA under the Victims of Crime Act funding, which we received 59,000 for in FY 2020. And just this fiscal year, we were awarded an additional 54,000. So this foster care sponsorship bill is definitely going to be a big plus for the Division of Youth Services. With the extra funding that came in, it kind of like helped us stabilize the program. But it wouldn't hurt to get this in place so that in the future, if the need is there, then we're all geared up to kind of provide that additional support. So what we see this bill helping is to also provide additional incentives for the foster care parents so that we will be able to recruit and maintain our foster care pool, because as it is right now, it's one of the biggest challenges that we have. So the current support, you name it, we go from counseling, besides the stipend, we pay for counseling and all the other support programs, transportation. We accompany the children to their medical appointments, other appointments. We provide clothing and footwear for school. We provide school supplies, and pay for their medication as well if they do not have Medicaid or other medical insurance. So like I said earlier, hopefully we get this additional. We're going to work on enticing more community members to be part of our foster care pool, and also work on providing additional incentives. And this includes training for our foster parents with the help of this foster care sponsorship bill. And we're also here this morning. After Julian speaks, we'll be available for any further questions.
Thank you, Ms. Sublime. Thank you, Ms. Sublime. Mr. Camacho, did you want to proceed?
Sure. My name is Julian Camacho again. I'm the Child Protective Services Supervisor and Foster Care Coordinator. Currently, we have 6 children in our shelter. We've been looking for foster parents. We had some people that are interested in joining the program, but they want newborn babies. They don't want like older kids. So we're running into that. We're still looking for um, foster care parents. I have 6. One has been in the shelter for over 5 years. Yeah, so yes. Thank you.
I think in addition to that, the extra challenge that I can think of is we are always looking out for the best interests of the children. So we might have a foster child or foster children hopping from one home to another. So that also adds on to our layer of recruitment and retention.
Well, thank you so much for all that you do for these children who are at risk and in need. So this legislation, you assisted in the drafting of the bill, is that correct?
We had some input, yes.
Okay, and what it would change for the program is it would give you the authority to provide other incentives and expand your programs that from what you are currently offering to recruit and retain foster families. Is that correct?
Correct.
Okay, and then you'd be able to also seek other, like more private donors and other funding sources beyond legislative appropriations and federal grants.
Correct.
Okay, thank you. Any questions for our DYS guests? Thank you so much. We appreciate your testimonies today.
Thank you.
Thank
And
you.
if you could provide your written testimony to the Sergeant at Arms. Are there any other public comments? Looks like there are none, so we will move on to in our order of business. Colleagues, we are out of time. The JGO committee will be taking over this chamber very shortly. And so I wanted to just open the floor for our vice chair to introduce the substitute bill that we worked on with the Medicaid agency for House Bill 2253. And then if after any discussion and or adoption, we will adjourn and call our next meeting to take up the other items on this agenda. So with that, Vice Chair, you have the floor.
Thank you, Chairwoman. So I would like to present House Bill 2253, House Substitute 1, to further enable recruitment, retention, and appropriate classification and compensation of Medicaid personnel and for other purposes. The purpose of this bill was originally commingled with an appropriations bill that was later addressed by our Ways and Means Committee. Thank you, Chairman Manglonia. Since then, we've had several conversations, as discussed earlier, with the Medicaid team. And so this bill would change and remove the appropriations part, as we've discussed, and just make sure that we cover all the needs so that we can be in compliance with the federal mandates. And so I move to present this House substitute.
Thank you, Vice Chair. The motion has been made. Is there a second? And that has been seconded. Discussion. And so just to be clear, we are accepting the substitute bill being offered by Representative Staffler, but I'd like to ask that we hold off on drafting the committee report, Council and Claire, since we did receive additional comments and requests for amendments from OPM, and I think those are worth reviewing and revisiting with the Medicaid agency before we adopt the committee report and present this to the House. Are there any objections to that?
No objection.
Did you?
I just had a question. It may not pertain to anything up our. Sorry, it's related to this, but in the sense that the version in the budget bill is similar to the substitute version or the
Yes.
original version. Okay.
Yes, it's the language in the substitute version is what was basically adopted almost verbatim in the Senate's version of the
Okay.
budget. So and that was a request of the Medicaid agency that in the event that this legislation, the permanent legislation, isn't adopted before the end of the fiscal year, they'll at least be able to retain their current staff. And while we work on permanent legislation.
Okay. So any concerns from OPM to this bill would also would be reflected on the House budget bill then?
Possibly. I
Okay.
think that is, the OPM director was aware. I did let her know that this language was included in the
Okay.
Senate's version of the budget.
All right. So clarified. Thank you.
Okay, thank you. Are we ready to act on the motion? All in favor of the motion to adopt this substitute bill, please say aye.
Aye.
All opposed, say nay. The motion carries. This House Bill 2253, House Substitute 1, is now accepted and adopted by the committee, and we will continue to entertain amendments requested and proposed by OPM and perhaps other agencies. We will skip over the other items on this agenda. The other House bills, we'll take these up at the next meeting of this committee. Are there any announcements? Okay, there being none, I did want to just notify the members that the medical travel assistance legislation reforming our medical referral program has been pre-filed this week. Thank you, colleagues, for your support. And I expect to be introducing it formally at our next session and that it will be referred to committee. I've also asked if Ms. Sablon, Ms. Clara could begin drafting the committee report, just because we have already collected a lot of comments on the program through our public hearings and other testimonies that we received. So we can get started on the committee report and then take up the bill at our next meeting. Does that sound
No objection.
agreeable? Okay. All right. Thank you. Any other items under miscellaneous? Okay. At this time, may I ask for a motion to adjourn?
Motion to adjourn.
Motion has been made and seconded. All in favor of the adjournment, please say aye. All opposed, say nay. Motion carries. It is now 10:07 a.m. and this meeting is adjourned. Thank you, colleagues.